Cochrane review and systematic review and meta-analysis. And I'm also happy to have seen more senior author as well with us, Prof. Richard. So the title of this systematic review and meta-analysis was, well, investigating amyloid beta targeting monoclonal antibodies for people with mild cognitive impairment or mild dementia due to Alzheimer's disease. So just to maybe give some perspective first, as we know, Alzheimer's disease is one of the leading causes of dementia worldwide. And also I was encouraged to make this a bit interactive to keep you awake mostly, so feel free to participate. So the first question is, what do you think, how many million currently are suffering with Alzheimer's disease? You have 4 options, so you have 25% of chances of guessing. Anyone? And any volunteer, any number. All of these numbers actually have some meaning. So so if no one is happy to volunteer at the time until you warm up, I can say that it's 57.4 million people suffering with dementia worldwide in 2026. The other numbers offered have also importance. So 26.6 million was 20 years ago. So we can see that the number is more than double in 20 years. 20.2 million is, so the earliest data we have is from 90s. So we can see there wasn't much of a difference in 20 years then, but now it's doubling, and the prediction is that by 2050 it will be 106 million. Especially the expected increase of 68% in low and middle income countries due to aging population as well is another concern that we have to think about. So this is the number of people currently suffering with Alzheimer's disease. Again, question if there are any brave volunteers. Mild cognitive impairment doesn't necessarily mean dementia straight away. What do people think? What would be the percentage of people who will have the reversion of their symptoms, whereas although they would experience some memory difficulties, they can recover. So if anyone wants to try to guess, there's 33% of chance to guess now. If there's anyone wants to try. Okay, so 26% will go into something we call the reversal rate, basically people who will not develop any further symptoms or dementia. Now 15% of people with mild cognitive impairment will develop dementia within 2 years, and 33% will develop it within 5 years. Now just a little refresher slide about non-modifiable and modifiable risks for dementia. So we have age, genetics, and family history, and then there are a number of medical and physical risks that are known to cause memory decline. The main thing about this slide is just to have in mind that there is quite a lot of time between when amyloid starts accumulating along with other neurodegenerative changes until we actually see some changes clinically, which we first call mild cognitive impairment and later on dementia. So it's assumed to be 10 to 15 years. And this is really important because mostly we do not know that there is anything to treat or that anything is developing in the background. So treatment-wise, up to 2021, we had no disease-modifying agents, and drug therapies that were used would be cholinesterase inhibitors and memantine, with some proven limited effect in at least stabilizing and slowing down the disease, but no real treatment. There's also cognitive oriented treatments that were somewhat effective, like cognitive stimulation, cognitive training, and cognitive rehabilitation. Up to the era of amyloid beta targeting monoclonal antibodies, which potentially were hoped to be disease modifying. The way of action would be binding to amyloid beta and clearance through microglial phagocytosis. This way, stopping the death of neurons. And there was a big hope that this might help and revolutionize the treatment of dementia. And this is why this review as well is so important as well to see where we come so far in terms of that. So there are first and second generation of amyloid beta targeting monoclonal antibodies. First generation was mostly targeting amyloid monomers, while the second generation was targeting aggregated amyloid plaques. Now, the administration is mostly IV, with some newer forms also being available subcutaneously, and they're mostly administered every 2 to 4 weeks. Main side effects are ARIA and infusion reactions. In terms of ARIA, they're divided to ARIA-E, which are more edema, vasogenic edemas, and then ARIA-H, microhemorrhagic events. So methods used for this systematic review were the ones approved by Cochrane, so methodological expectations of Cochrane intervention reviews. And authors just mentioned that the only difference between the protocol and review was that they extracted number of people with any ARIA-E and any ARIA-H separately. Types of studies were randomized control trials. All studies, they looked that they last at least 12 months. This is also important because of the nature of the illness, which also is long-standing and takes time. And they looked into all randomized control trials up to 7th of August last year. So the longest studies were 48 months. They looked into all participants age over 18 with mild cognitive impairment and mild dementia. So it was specifically not more severe types of dementia, mild dementia and cognitive impairment. And they looked into amyloid beta targeting monoclonal antibodies of any dose and by parenteral route. They allowed concomitant use of other medications, but they needed to be used then in both arms. And they compared with placebo, no intervention. What they looked into. So they looked into benefits, cognitive function, dementia severity, and functional ability mainly, and harms that they were looked into was ARIA, amyloid-related imaging abnormalities, symptomatic brain hemorrhages, serious adverse events, mortality, and infusion reactions. Now, here we have Prisma, where we can see that they looked into 3 databases and 2 clinical trial registers. They identified 13,500 references. They didn't identify any references from other sources. Once they removed all duplicates and studies that were not meeting criteria for either design or intervention and other, they got the number of 17 trials. They looked into different medications, obviously different amyloid beta targeting monoclonal antibodies, and they also identified 6 studies that are still ongoing. So altogether, the studies that were singled out, 17 of them, there were over 20,000 participants in the period of 10 years between 2014 and 24. They looked, it was between 18 and 27 months, and mostly it was done, most of the population were white in Europe and Northern America. So this is now where the figures start and where I'll be also asking more participation. Sorry, I lost my now view. Press something.
Okay, so I mean, we're at it. So Dr. Dinesh, I mean, wanted to add a slightly newer risk factor in the literature, which may be of interest, air pollution. I think that's yeah, that's something also important maybe to look at, especially now with the problem of pollution, climate change, and so on and so forth. And maybe we need to have like several decades of exposure to be able to really see the difference. So this is maybe another risk factor. I mean, is it modifiable? Yes, but not easily so.
Yeah, it's a great point, and I will maybe touch base even later when we talk about limitations of the study and future, what could be done in the future reviews. So, okay, so here, so it's figure 2. It's the first one and one of the main ones that we'd like to analyze. You can see here risk of bias and the legend that is looking into bias arising from randomized process, from intended interventions, outcome data, measurement of the outcomes and reporting results, and overall bias. The main thing here with forest plot, this one is looking into effect of monoclonal antibodies versus placebo on cognitive function. So as I mentioned, they looked into cognitive function, into obviously functional abilities. So first one in terms of cognitive function, now just to maybe refresh about forest plots. So
okay, let's see if someone wants to just interpret the graph. So, I mean, as with any meta-analysis, there's usually one main outcome that needs to be looked into. So for this meta-analysis, it was the ADAS-Cog score, so the cognitive function at 18 months. And then there are obviously secondary outcomes as well. So does anyone want to read the, this is one of the most important, maybe the most important figure in the whole study. So this first plot. So any questions? I don't know, anyone can comment who can comment this or read the forest plot. Otherwise, yeah, we'll read it together. Okay, I think the most important part is to look at, of course, yeah, you can, I mean, Dr. Carol, if you want, or okay, I can also show it here maybe. So the most important part is this one, as you can see here. So we will need to look at the different studies one by one, as well as the pooled here. I mean, as when you have this black like lozenge, it's actually the pooled data. And very clearly we have the confidence intervals here. So, I mean, anything that crosses this line actually means that the result or the outcome was not different from placebo, okay? Anything that does not cross the line was significantly different from placebo. So yeah, this is how we can read it. And of course, we always also have a look at the risk of bias. So if a study has a statistically significant result, this doesn't obviously always mean that it's clinically significant. There are a number of things that we need to look at as well, the effect size, the risk of bias, so that, I mean, we can tell with confidence if the result was actually positive and clinically significant. Okay, so yes, Dr. O'Carroll, you can continue.
So yes, here you can see that all of the studies are crossing the line, which means that they're not statistically significant. So we look into two things. First, whether they cross the line, and also p-values. So neither of those were significant for these studies. Now, the next slide. Not sure.
I mean, there was one here that was barely significant, the first one. But then, I mean, in a meta-analysis, we'll look at the pooled result, and the pooled result for each of these compounds, the pooled result was actually negative. If you have, I mean, the three lozenges crossed the, so.
I have some technical issues with moving my slide, which I'm not sure why is it happening.
Okay, just 1 second. Yeah, I think maybe it's me.
I think I wasn't sure who was turning on the.
Yes, now I think you can.
So not yet.
You can you highlight it then?
Not able to move it, unfortunately. I can try from scratch if that would help. There. Is this okay now?
Yes, it's working.
Okay, so here you can see that there are two studies that are statistically significant even by p-values, but also by the fact that they're not touching the line of no effect. This is donanemab and lecanemab. And also we can see that there is a statistically significant total result, but it's just slightly, it shows a small effect that is statistically significant.
Well, here it's important also maybe to say, okay, so here we're also always talking about statistical significance, and then we will see if the effect size actually makes sense in clinically. So think of the statistical significance also as black or white. So okay, the statistical significance is there, but we will see what's the effect size actually, and is it clinically relevant or not.
And now, not sure what's happening. Okay, so the next one is forest plot showing again effect of monoclonal antibodies versus placebo on dementia severity. And the same thing applies again, looking at the studies that are clinically significant here. We have 3. Does everyone see that? So it's crenezumab, donanemab, and lecanemab. Those 3 are significant by p-values and also by the fact that they're not touching the line. However, this is just showing a very small improvement into the treatment of dementia. So as you can see, the total result, it's touching the line of no effect. So it's minus 0.00. So it just shows a very minor effect. The next one is forest plot looking into monoclonal antibodies versus placebo on functional ability, which was another characteristic that was looked into by the reviewers. And here, can anyone notice anything interesting about these 2 studies that were looked here? Any volunteers? So look at the first study, crenezumab, and the second study, solanezumab. So look at the numbers here. So the total number of participants here is 12 plus 15, so it's 27, whereas we have nearly 3,500 in the second study. So while the first study showed no statistically significant effect, but the second study basically holds the 99% of the weight of these 2 studies. And again, it's showing a small, statistically very small statistical effect That's if you want to add something, Dr. Ioannis.
Yeah, so I think it was clear.
Yeah.
So we can move.
Move to next one. So figure 7 is looking into what we mentioned being the main side effects, amyloid-related imaging abnormalities, and the authors divided them into E and H, looking into edema and looking into microhemorrhages. So here, again, the same thing is looking into which studies were statistically significant. So we have the first two, and look at the p-values as well. So very statistically significant, and also they're not crossing the line of no effect. And then there is donanemab and lecanemab as well. So the interesting part here is maybe just pointing out that they looked into treatment and placebo, and they looked into events and total. So you can see down that while total number of people with ARIA-E was 6,878, only 972 had events. And this is very important because the main concern with ARIA as a side effect is that they're silent MRI findings and they're asymptomatic. So this will be important later on as well, just to comment as limitation of the study.
And you will see that there was a problem with many studies not actually mentioning these symptoms. So we're going to talk about that later on.
And the next one is forest plot showing again facts, but here they looked into symptomatic ARIA-E, and there were only 2 studies, which were both statistically significant, showing that obviously symptomatic ARIAs are significantly more common. Here you can see that it was obviously very like risk ratio was 53 times more. Anything else anyone wants to comment? This one, we'll go to next. Yeah.
I think, I mean, we'll talk about this later on as well. But this is one of the problems when like a medication gives you like side effects that are much more common than placebo. As you can see here, there's always a problem of functional unblinding. So even though you blind participants might tell, because of the occurrence of these adverse events, they might tell that they are on the active component on the placebo. So there's an expectancy bias, and this can favor the medication, the active medication, because people might, I mean, it can alter the blinding. We'll also talk about this later on. But this is like common in any medication that has a side effect that's immediate and that occurs with like a very high frequency compared to placebo.
Next one looked into amyloid-related imaging abnormalities in terms of hemorrhage. And here we can also see that there was statistical significance in both studies, except the last one where there was no difference. And then going to the next one where they looked symptomatic only hemorrhages, and this was only one study. So it showed 3 times more likely of having symptomatic hemorrhages, but in general, they seem to be symptomatic hemorrhages in general are rare. And just to kind of summarize last 4 slides, so basically authors found that any ARIA-E was 10 times more likely, which we've seen on the slide here. And then symptomatic ARIA was statistically significant and increased, but very uncommon. We have again 2 times more likely to develop ARIA-H, but then again, symptomatic ARIA-H being very rare. And this is, as we remember in the slide before, that most people have asymptomatic ARIA-H, and the way they're discovered is because when obviously treating people with monoclonal antibodies, there is substantial as well cost to that because they need to be first administered IV, and secondly, they need to do PET scans to look for these side effects. And now coming to the slide 11, there is only one statistically significant study here. Anyone brave enough to mention or to name the study that's the only relevant statistically? This is the second one, papineuzumab. And then again, in total, there was no statistical significance to, this is where they looked into placebo versus monoclonal antibodies on serious adverse events. And one of the reasons why there is no statistical significance is because most of the side effects are asymptomatic. And again, one of the limitations was that many of symptomatic ones were not reported in the studies. So going to the next study here that looked into mortality rates, it didn't find any statistical significance. Any idea why this would be the case? So also the studies were not long enough, and we'll look into maybe the age of participants as well later on. Now let's see if anyone...
Who can recognize this? What's this? Okay, you can just unmute and talk or write in the chat. Otherwise, yeah, just give the answer.
Yeah, if anyone wants to even write in the chat. So this is, well, we just hit the title to be able to ask this question if anyone wants to share. But so this is funnel plot, and this is used to look into publication bias. So the large studies are at the top, and they have lower, obviously, SE, as you can see there. So they have larger number of participants, and normally it's called funnel plot because it looks like a funnel. So we can see here that studies with smaller studies that have a higher SE, they are at the end, and there is no asymmetry in the funnel plot, which there is no obvious publication bias, but the limitation of this is the fact that there's not enough studies to make this conclusion. So there is a limited number of studies. So it's hard to judge, but there is no obvious publication biases from what we could see in the studies. And now another funnel plot looking into any ARIA-E for publication bias. If you remember, I mentioned that ARIA-E were 10 times more likely to occur in patients receiving monoclonal antibodies, unlike ARIA-H that was only 2 to 3 times more likely. So again, the same larger studies at the top, lower studies, they do form some sort of a funnel. So there's no obvious publication bias, but again, limitation is that there's not enough studies. And we're coming close to the ending and time for discussion. So conclusions of this study: first, the effect of amyloid beta targeting monoclonal antibodies in patients with mild cognitive impairment or early dementia due to Alzheimer's disease on cognitive decline, dementia severity, and functional outcomes over 18 months period is absent or consistently small. Secondly, there was small functional improvements, but there was no, again, dementia severity difference. And this is just a refresher that what clinical outcomes they used and what scales they used to assess this. Third conclusion is that true effect size may be even smaller because of functional unblinding, as Dr. Juanes mentioned, that due to side effects, although it was obviously randomized controlled trial and blinded, but when side effects emerged, participants and investigators rightly so assumed that this person might be receiving treatment. And another thing is that was found that there was no increase in serious adverse effects at 18 months' time. For conclusion is that risk of adverse events in terms of ARIA is very high, but they're rarely symptomatic, and therefore true impact was not explored. And there was little to no difference to ARIA E and H. Again, to mention the significant cost of medication and monitoring because it needs to be administered IV in a hospital setting and followed by PET and MRI scans. So the main conclusion is that amyloid beta targeting monoclonal antibodies do not offer a favorable benefit to risk balance with mild cognitive impairment and mild dementia caused by Alzheimer's disease. Limitations, as I mentioned earlier, the age of participants was between 70 and 74 years, while average age of patients with dementia would be around 80. So most of them were much younger than we would expect. And then again, there was lack of data on symptomatic ARIA. Expectancy bias due to this functional unblinding that we mentioned is another limitation. All of the studies were funded by pharmaceutical companies. And again, also the short follow-up, as this is a neurodegenerative disease with a long course, so this was fairly short follow-up to be able to tell conclusively. Again, selection bias in all of the studies. There was fairly low ratio of participants comparing to number of people that were treated in that center. And again, lack of data on education and social background. And as Dinesh mentioned, maybe including something like pollution effects as well, which are inconsistent, not same in all countries. And most of the participants were from Europe and North America. Again, strengths were very robust methodology and the fact that all studies to date were included. Implications for research would be transparent report on ARIA and their clinical manifestations. Again, to explore new mechanisms of action as other than amyloid removal, like reducing inflammation and emerging new area as well of gut-brain axis as one of the factors. Future studies on drug treatment to collect data on baseline risk, particularly modifiable ones, socioeconomic status, education levels, again, other risks like pollution, prioritize clinically meaningful outcomes with longer interventions and follow-up periods. And again, inconsistent reporting of other groups, as I mentioned, nearly 84% were from white background. So other populations and ethnic groups were not represented equally. So the future trial designs need to look into improving this as well. And thank you everyone for listening. You have this QR code and we'd appreciate your feedback as well.
Okay, thank you very much, Dr. Carol. I think you can keep the QR code, maybe
I
make it a
will.
bit bigger for them. I mean, you can. We're
Yeah, if you
pleased to have
want to
your
try.
your
Oh
feedback.
gosh, I'll need to go. Having a
Okay, no
bit of
problem. I
technical
mean, in
issues.
the meantime,
Yeah.
so we're also happy to have Professor Richard with us, the last author of this article. I don't know, my own conclusion for this article is that statistical significance doesn't mean clinical significance. So even like here, there was a statistical significance for ADAS-Cog, for the CDR sum of boxes, but the like effect size was so small, like the standardized mean difference was less than zero point 0.2 for each, was about 0.1 or 0.11, 0.12 for each of these outcomes, for example. And in absolute terms, like people improved by less than 1 point on average, and like on ADAS-Cog, which is clearly not clinically significant. Again, on the CDR sum of boxes, also they improved by less than 0.3 points over 18 months, which also is not, I mean, significant clinically, I think. I don't know. What's your opinion, Professor Richards?
Well, thank you, Sami, and thank you very much, Jelena, for so punctually summarizing our Cochrane meta-analysis. Yeah, I'm afraid I have to agree with you, Sami, that unfortunately these medications do not offer clinically meaningful benefit to patients or their caregivers, and the risk of bias in the results is quite high, particularly as you mentioned, the functional unblinding. Another point that was not mentioned so immediately, but particularly in the lecanemab and the donanemab trials, which are driving the small effect size, that we do find there was a higher dropout in the intervention arm, which adds to additional bias, having the people doing worst in the intervention arms dropping out and not providing data for the final assessment. So as much as I would like to have any good treatment for my patients in the consultation room, I'm afraid this type of drugs will not offer that.
So in clinical practice, what's your, okay, because we are receiving patients, with Alzheimer's disease, with like MCI, early dementia stages, and they heard about these medications, or at least their children oftentimes looked into these medications. Do you think that they might be worth using in certain subpopulations? What's your clinically, let's say in clinical practice, what's your recommendation?
Well, first, if patients ask me something like that, I just stick to one simple rule, and that's be honest about it. And then I would tell them that there is no chance that they will have that they will notice any difference when they take these medications. And I explain to them the potential adverse events and the burden of getting these drugs. However, in the Netherlands, these drugs are not reimbursed, so it's not really an issue in our place. Consistently, I hear people saying, well, we should really try to provide the drugs to subgroups of people who may benefit most. But I think this is a very dangerous approach because there's no scientific underpinning for doing so, because no subgroup analysis have been performed that would show that would suggest such an effect. And even if you would find a subgroup in which a larger effect would be suggested, this is insufficient to start prescribing these drugs. Then you need to design a new phase 3 trials in this specific subpopulation, because we know that the chance that there's a high risk that any effect in a subgroup is a chance finding, and that it's often difficult to reproduce in a new trial. So I think there's really no scientifically valid argument to start prescribing this to specific subpopulations based on the data we currently have.
And what do you think went wrong? Like these medications, radiologically speaking, they're effective. I think they are clearing the beta amyloid. Why do you think? They're not being as effective clinically. Is it because they are used? Maybe even the MCI stage is too late. Maybe we need to find other targets. I mean, we have tried so much, I mean, targeting, we have tried to target the beta amyloid monomers and polymers. Maybe we need to look elsewhere. I don't know, or maybe there's another reason why maybe these medications, although they're working radiologically, they're not really working clinically.
Yeah, so for me, this is a typical example of a drug that works but doesn't help. It's effective, and in itself, it's a scientific breakthrough that the protein can be removed from the brain. That's an amazing achievement. But on the other hand, it's not a big surprise to me that it doesn't lead to clinical benefit, because we've known for more than 25 years from large autopsy studies that the amount of A beta in the brain correlates very poorly to cognitive functioning. There are many older people with quite considerable abnormal amyloid beta in their brain with absolutely no cognitive impairment. So, and we knew from the earliest studies on already that even if you could effectively remove these drugs, it doesn't affect cognition. So I think, to me, this is a confirmation that there's no direct link between the presence of amyloid in the brain and the cognitive function, because if you remove the amyloid clearly, effectively, it doesn't affect the cognitive decline. So personally, I think we should go back to the drawing table and conclude that other mechanisms are probably more important in determining the cognitive impairment. And whether or not this has to be somewhere linked to the amyloid cascade hypothesis or a completely new approach, it's uncertain at this moment, I would say.
That's interesting because, in psychiatry, we usually do it the other way around. So in psychiatry, as you know, most of our medications were discovered by chance, let's say, randomly. So they were discovered clinically, and then we tried to find neurobiological hypotheses to better understand the depression, for example, schizophrenia, etc., based on the hypothesized mechanism of action of these medications. So here, in Alzheimer's, it's the other way around, just a normal medical way of, and trying to understand the pathophysiology of a disease, and then trying to, have develop medications that target this pathophysiology, but still it shows how things are very complex. Maybe this is like only just one phenomenon among many others that we don't know yet that are driving the neurodegeneration and like the cognitive decline. Some people may say it's maybe too late because once the cognitive decline started, but again, there's an ethical problem when we start such medications in people who have evidence of beta amyloid pathology in the brain, but who don't have any evidence of any cognitive decline yet.
I agree with you that that's an ethical challenge. However, it has been done in the USA in the A4 trial. So asymptomatic people with an abnormal PET scan have been included in a randomized controlled trial. And also in this population, and I think on the top of my head, this study was not in our meta-analysis because it's a different population, but they were followed for several years, and there was absolutely no difference in occurrence of cognitive decline and in trajectories between those who were amyloid, who received the drug, who didn't receive the drug. So also that argument, some evidence already supports that it doesn't hold. And moreover, if you would say the quintessential amyloid beta related Alzheimer's disease is people with a genetic mutation in, for instance, the presenilin gene. These people really have an amyloid beta metabolism disorder. But also in these populations, so genetically inherited Alzheimer's disease at a young age, some of these drugs, including gantenerumab, have been tested in randomized controlled trials, and they also did not show any benefit. So I think if you approach this with a Bayesian lens, and you think after having all this evidence of no clear effect, it's becoming rather unlikely that in a future trial this approach will be beneficial. And therefore, I think the field would really advance probably faster on the long term if we would more actively use other approaches, explore other disease mechanisms, and perhaps even simply park the amyloid beta cascade hypothesis for a while. We don't have to throw it away altogether. But it's very clear now that at the very, very least, the hypothesis is incomplete. So it would be very good to use some blue sky thinking and really try to explore other mechanisms. And this is not a pleasant message for current patients, because from the moment you start exploring other disease mechanisms, if you ever make it to an effective drug, it will probably take 10 to 15 years. But I still think on the long term, it has more chance to be successful than continuing on the same path with monoclonal antibodies against amyloid beta.
That's very, very important, I think. Maybe also tau might be another maybe target, but again, I'm not sure this is the right target, and it's shared with other types of dementia as well, not just Alzheimer's disease. But again, maybe we need to focus on other things. GSK3, insulin resistance,
Yeah.
neuroinflammation, other mechanisms, completely different mechanisms. Okay. Anyone who has any question, any comment? Yes. Okay. Yes. Go ahead. Go ahead, please. Yeah.
Hi,
So,
hi. My name is Saba. I'm actually a neuropsychologist. I accidentally came across your poster today, so I'm very happy I did. I did all my training in India, and something that struck by me is when you said that statistical significance is not always clinical significance. And this statement, when you say it out loud, you get a lot of looks, and people are not happy when you say it, because then they're like, "How do you do science?" But thank you for saying that. And something similar that Dr. Richard said is that, it's a difficult thing to say, I think, but that, you got to park the hypothesis for a while, and so much work has been already done, but it's a brave thing to say about these things, and it really resonated with me. So thank you. Thanks a lot, because both of these statements, it's very hard. Nobody wants to listen to this, but you can't do science without saying the hard things, right? So thanks a lot for that. Yeah, thanks to both of you all.
Thank you. This is very kind. And if you encounter people again, you can always refer them to Sami or me. We're very happy to explain the difference between statistical significance and clinical meaningfulness.
I think this is.
Yes, sir. Thank you. I just want to say, my mentor is someone like you. I did my training in dementia, and during the pandemic, somehow switched to the pediatrics. So now I specialize in neonatal neurocognition. This is something dementia always, MCI is something that has my heart, and I'm like, you know what, I should just attend the talk. And everything was just refreshed, like all my training came right in front of me, that do not forget what clinical significance is, do not forget to say the hard things. So thank you, both of you. You just made my day. Thank you.
Thank you very much. Thank you. Any other questions or comments? But I think if there's a take-home message, especially for like early career psychiatrists here among us, again, so statistical significance is important, but you also need to have a look at the risk of bias. This is very important, and then you also need to look at the effect size. I mean, a good example would be, okay, if we develop an antihypertensive medication that decreases blood pressure by 1 millimeter of mercury, I mean, it can be statistically significant with enough power, with a good enough sample size. We can prove it. But would you prescribe this medication to people with hypertension? That's the question. So that's exactly, I think, the take-home message. Okay, so thank you very much for attending. Thank you, Dr. Yelena. Do you have any comments or yeah?
Thank you so much. It was nice hearing Prof. Richard thoughts as well of maybe parking and trying to focus on other things, not completely forgetting about it, but maybe explore other options. And that's take-home message for me as well.
Thank you very much. Thank you very much, Professor Richard, again, for being here with us today. We obviously learned a lot from you through the article, and then thanks to your presence with us today. Thank you very much, everyone, and have a good night or good afternoon or good morning, wherever you are. Thank you. Bye.
Bye.
Thank you. Bye.